Hello and welcome to the emergency and acute theme. This video is on sepsis in adults. So what do we already know? Question 1. Which of the following is a red flag for sepsis? A. Responds only to voice or pain or is unresponsive. B. The relatives are concerned about the patient's mental state. C. The patient is immunosuppressed. Or D. The patient has a systolic blood pressure of 91 to 100. Remember, there is a difference between red and amber flags, with red flags being more serious. The correct answer is A, responds only to voice or pain or is unresponsive. All are important flags that you might come across in septic patients, however you'd be most concerned about a deteriorating AVPU. These patients are very sick. Question 2. In what age group are 2/3 of sepsis cases in the UK diagnosed? A. Under 25, B. 25 to 50, C. 50 to 65, or D. 65 and over. Think about which group is the most susceptible to infection. The correct answer is D. 65 and over. This age group are more prone to infection and therefore more prone to sepsis. Finally, question 3. Within what time frame should the Sepsis 6 be implemented? A. 30 minutes, B. 60 minutes, C. 90 minutes, or D. 120 minutes. Remember that the aim of the Sepsis 6 is to initiate treatment as soon as possible. The correct answer is B. 60 minutes. We will cover the Sepsis 6 later on in this video. This presentation is going to give you a brief overview of sepsis and its management in the emergency setting. I will cover what sepsis is, its symptoms, acute management looking particularly at the Sepsis 6, some investigations and differentials, and finally some general and OSCE tips. At the end of the presentation, we will also have a few more questions to consolidate our learning. So what is sepsis? Sepsis is defined as a life-threatening organ dysfunction caused by dysregulated host response to infection. This dysregulated response causes the classical signs that we see in septic patients. Some patients present with septic shock. Septic shock is a subset of sepsis, with persistent hypotension requiring vasopressors to maintain a mean arterial pressure of more than 65 and a lactate of more than 2. Systemic inflammatory response syndrome, or SIRS, is defined as a non-specific response to an infectious or non-infectious insult with 2 or more of the following: a temperature above 38.3 or below 36, tachycardia, tachypnea or PaCO2 under 4.3, hyperglycemia in the absence of diabetes mellitus, acutely altered mental state, or leukocytosis or leukopenia. Sepsis used to be defined as SIRS in the context of infection. This definition for sepsis is now no longer routinely used. Similarly, severe sepsis was defined as sepsis associated with organ dysfunction, hypoperfusion, or hypotension. However, the revised definition of sepsis in 2016 means that this term has now been made redundant. So what are some of the signs and symptoms of sepsis? High or low temperature, arterial hypertension, tachycardia. The dysregulation of the immune system releases products like nitric oxide that cause vasodilation and increase the capillary permeability. With the vasodilation, cardiac output initially is compensated for by increasing the heart rate. However, later on, the heart may begin to get tired, so as a result, hypotension and hypoperfusion may develop. Tachypnea, acutely altered mental status, poor capillary refill, mottled skin, or an ashen appearance. Signs of infection source: low oxygen saturation and decreased urine output. Kidneys are very sensitive to blood pressure changes, and so they are very quick to respond to hypoperfusion. Less blood means less urine will be produced. Cyanosis and purpura fulminans, which is a sign of pneumococcal septicemia. It is also important to get as much information out of the history as you can, as there are many risk factors for sepsis. These include malignancy, age over 65 years, if the patient has immunocompromised, hemodialysis, alcoholism, diabetes mellitus, recent surgery or other invasive procedure, breached skin integrity, indwelling line or catheter, intravenous drug misuse, and pregnancy. Sometimes when patients are critically ill, it is necessary to take a collateral history from friends or family, or from a healthcare staff that have been looking after the patient before. As mentioned in the question at the beginning of the video, there are a number of red and amber flags that should make you think that a patient might have sepsis. The red flags are: responds only to voice or pain or is unresponsive, acute confusional state, systolic blood pressure of less than 90 or a drop of more than 40 from the baseline, a heart rate of more than 130, respiratory rate of more than 25, needs oxygen to maintain an oxygen saturation above 92%, a non-blanching skin rash, mottled or ashen or a cyanotic appearance, a lactate above 2, recent chemotherapy. The amber flags are: relatives concerned about mental status, acute deterioration in functional ability, immunosuppressed, trauma, surgery or a procedure in the last 6 weeks, respiratory rate of 21 to 34, systolic blood pressure of 91 to 100, heart rate of 91 to 130 or a new dysrhythmia, not passed urine in the last 12 to 18 hours, a temperature of below 36, or clinical signs or a wound, device or skin infection. If there is any one red flag present, the patient looks sick, and you think that this could be due to an infection, then the sepsis 6 should be started immediately. If there is an amber flag present in a patient that looks sick and could have an infection, then blood samples should be sent and reviewed within an hour. The patient should also have a senior review. If AKI is present, the sepsis 6 should then be started. Patients who don't fall into these criteria may be safe for discharge, ensuring there is adequate safety netting in place in case of deterioration. This is down to senior clinicians' discretion. The UK Sepsis Trust has produced an ED or AMU sepsis screening and action tool that is used in many trusts across the country. It's very useful for guiding you through, step by step, what should be done for a patient that has sepsis. The same tool includes details on the sepsis 6, again guiding you through exactly what needs to be done. The sepsis 6 are a bundle of therapies that have been shown to improve outcomes in septic patients. They should be completed within the first hour following recognition or suspicion of sepsis. The sepsis 6 have been shown to reduce mortality by up to 50%. To complete the sepsis 6, you must administer oxygen with target saturations above 94% or 88 to 92% in CO2 retainers. This can be done using a non-rebreathe mask on 15 litres of oxygen and then adjusted as per the patient's response. Take blood cultures and consider other samples like urine or CSF. These samples should be taken before any antibiotic therapy is given in order to correctly identify a causative organism in the samples and to identify antibiotic sensitivities. Give IV antibiotics. These should be broad spectrum initially to cover all possible bacterial causes of infection, and trust protocols should be followed. Give IV fluids. Check serial lactate levels. Usually this is done using an ABG analyzer. Higher lactate levels are associated with poorer prognosis. Measure urine output, because as mentioned earlier, the kidneys are very sensitive to hyperperfusion, so urine output is a useful indicator of the patient's condition. The sepsis 6 can be remembered using the mnemonic Buffalo, and can also be remembered as give 3 and take 3. The acute management is other things you need to consider for a septic patient other than the sepsis 6. Some patients may not respond to initial treatment. In these situations, referral to ICU or HDU will be required as soon as possible. Constant monitoring of vital signs is essential in assessing response to treatments given. After any intervention, an ABCDE reassessment should be carried out. It is important to continually measure lactate levels. Poor lactate clearance is associated with poor survival. Don't forget to perform an ECG to look for a new dysrhythmia. Tachycardia could be from AF, or there could be a bradycardia. Further investigations to be considered can be performed to check a patient's performance and to guide further treatment. Normal blood tests can be performed, including FBC, UNE, LFTs, creatinine, INR and APTT, serum glucose, and CRP. Cultures other than blood cultures may be useful. Choose samples based on where you think an infection is coming from. For example, sputum for pneumonia, stool for a gastrointestinal cause, or urine for a UTI. A chest X-ray may be useful for looking for pneumonia if you think pneumonia is causing the sepsis. ECG may show ischemia or arrhythmias. A lumbar puncture may be indicated if meningitis is suspected. An echo may show vegetations in endocarditis and can help assess hypovolemia. An ultrasound scan can show fluid collections, abscesses, and biliary obstruction. And a CT chest or abdomen can show abscesses or effusions, which are signs of infection. As with any condition, you must consider your differential diagnosis. Some of the differentials for sepsis could include a non-infective cause of SIRS, such as trauma or burns, an MI, pericarditis, myocarditis, acute pancreatitis, a massive pulmonary embolism, leukemia, malignant hypothermia, or drug-induced fever and coma. So some general and OSCE tips. Some OSCE stations may ask you to interpret a news chart. Noticing trends in these charts may give you clues as to who might be developing sepsis. Tell the examiner, if you think a patient might have sepsis, they are probably very sick. Get familiar with the university news chart, as it is different to the ones used in practice. Hospitals can alter them to make a modified early warning score chart, a MUSE chart. Always reassess patients using ABCDE. If you provide any intervention, you think a patient is improving or deteriorating, or if a news protocol says that you should. And call early for help using SBAR or other structured handover. This can be used when handing over anything to anyone. So to finish this sepsis video, we will go through a few more questions. Question 1. Which term is no longer used to define sepsis? A. Sepsis, B. Severe sepsis, C. Septic shock, or D. Systemic inflammatory response syndrome? Consultants and doctors may still refer to all of these terms below despite the new definitions. The correct answer is B. Severe sepsis. This definition has been made redundant since 2016. Question 2. What are the sepsis 6? A. Oxygen, FBC, fluids, antibiotics, oxygen saturations, and serum lactate. B. Antibiotics, chest X-ray, blood glucose, white blood cell count, and CRP, and antibiotics. C. Blood culture, serum lactate, urine output, oxygen, antibiotics, and fluids. Or D. Blood culture, urine output, oxygen, antibiotics, fluids, and IV access. Remember that you can give 3 and take 3. The correct answer is C. And finally, question 3. How many red flag symptoms should you find before starting the sepsis 6? A. 1, B. 2, C. 3, or D. 4? Think how long you can wait before starting the sepsis 6 on clinical suspicion alone. The correct answer is A, only 1 red flag before you start the sepsis 6. Thank you for watching this video. I hope it has been helpful.